Welcome to our Richmond Historic and Genealogical Society program tonight. And I know that you're all aware of what the program is tonight. And is there anyone here who does not know our speaker? Because this man has probably touched all of our lives in one way or another through the many years that he's been here. So an introduction of Dr. Pat McClellan is probably not necessary because he has been a member of our community and a respected individual both in our community and the medical profession all of his life. And we're so very honored to have him as part of our Richmond family. And we feel very honored. Does it sound like a eulogy? I hope not. I just hope not. He's alive and well. We don't want to do that again, do we? Anyway, we do feel very honored to have him here and for him to share his expertise in the field of medicine with us. If you were lucky enough to be here for his other two programs, they were fascinating and interesting and educational. And that's all of his programs are educational and entertaining. And it's so nice to have him here. Welcome, Dr. McClellan.
I'm grateful for that. But in order to cover medicine from Medicare to the present time in approximately 1 hour, I obviously had to prioritize. And to be fair to an audience, I think you should know the background of the speaker, as he has biases when he selects or chooses not to select certain topics for the presentation. So just briefly, to elaborate on my background, private family practice for 40 plus years, hospital staff privileges at Mount Clemens General, St. Joe's in Mount Clemens, and River District in St. Clair. I was the medical director of Martha T. Berry, the County Extended Care Hospital. I was a deputy medical examiner for both Macomb and St. Clair counties. I was medical director of a home nursing care company. I was director of the family practice residency program at Mount Clemens General for over a decade. I held almost all hospital staff offices and many committee offices. I was medical director of the Mount Clemens General Physician Hospital Organization. The focus of that group was to evaluate quality and cost of healthcare. Currently, I'm a board member of the McLaren Physician Partners. Again, the focus of that organization is to evaluate quality and cost of healthcare. One of my prime loves in medicine is teaching. I began teaching medical students in 1966. I continue to the present. I've taught students in my office, at the hospital, in the classroom of the Osteopathic College at Michigan State, both here at Macomb and at the big house in East Lansing. And I continue to teach on the medical outreach clinic. There's a poster of the medical outreach clinic. That's a large truck with 2 exam rooms. We take it into the poorest areas of our community, mostly Mount Clemens, Romeo as well. Thus, I have worked in a variety of positions in the medical field and have seen and experienced the delivery of medicine from many different perspectives. The handout that you have is basically the way I chose to organize tonight's program. I'm going to use each letter of the alphabet to provoke a discussion of one or more topics. For A, I have chosen 2. The first is advocate. It is my position, and I'll try and elaborate on it later, that every person who enters any arena of healthcare today needs an advocate. I'll stop there and go on to the major topic represented by the letter A, and that's antibiotics. At the time of my introduction in practice in the 1960s, we had penicillin, we had sulfa, we had tetracyclines, and we had some derivatives of those antibiotics. Development of antibiotics did not proceed very rapidly for several decades. It was during this time that basic scientists learned the various ways to kill bacteria without killing the host. Those mechanisms include antibiotics that break the cell wall of a bacteria. Those are penicillins and cephalosporins. The one you probably know is Keflex. There are those that break the membrane of the cell inside the cell wall, and the polymyxin group is that antibiotics. There are those that poison essential enzymes in the metabolism of the bacteria. The sulfonamides, the sulfa drugs, and the quinolones do that. And there are those that stop protein synthesis in the bacterial cell. The macrolides, furidatin, and the tetracycline group do that. So that's one way to classify antibiotics. How do they work? Another way to classify antibiotics, perhaps more familiar to you, is by spectrum. Some antibiotics have a very broad spectrum. They kill a large number of bacteria. Some antibiotics have a very narrow spectrum. So for about 20 years, there was not a great deal of development of antibiotics as the basic scientists got their act together. And then the development was quite rapid. At the present time, the physician has probably 25 antibiotics in current use. Some are restricted, but these are the ones that are available to most in this column. The bacteria that they kill are in this column. The problem is the body of the graph is what the resistance has become to most of the antibiotics in current use today. And some of these numbers are as high as 90% of the cultures of that particular bacteria are resistant to the usual antibiotics. Antibiotic resistance is a big problem. It is a problem that belongs to physicians because we have overused antibiotics. Physicians have the evidence that they should not be doing that, but some authors say that physicians have the habit of writing too many antibiotics, and habits are hard to break. Second reason for the overuse of antibiotics is patient expectations. If a patient comes to the office expecting an antibiotic, it is very tempting for the physician to accede to that expectation and give the antibiotic. Third reason, there are other users of antibiotics. Dentists use antibiotics, veterinarians use antibiotics, farmers use antibiotics, animal husbandry folks use antibiotics. A big user of antibiotics is the cosmetic industry. One example is antibacterial hand soap. Now, the bacteriologist will tell you that one of the ways to teach bacteria to become resistant is a small dose of antibiotic frequently applied for a short period of time. That's antibiotic hand soap. One squid into your hands, wash and rinse. That breeds resistance, but also the chemical that is used by that cosmetic or soap manufacturer goes down your sink through the wastewater treatment plant, which has no recognition of this class of chemicals, and into our water table. At the present time, chemical residues from bacteriostatic or bacteriologic hand soap have been found in the geographic center of each of the Great Lakes. And the tragedy is nobody has studied what those chemicals do to marine life or plant life. The most dire prediction I have heard from some authors is we must learn to live in the post-antibiotic era. MRSA. Sandy and I have a relative who was recently devastated by a MRSA infection. That's multiple antibiotic-resistant Staph aureus. B, bariatric surgery. In 1965, when I entered practice, there was none. Now patients up to 618 pounds have been operated in my hospital successfully. Most of the surgery in bariatrics is done through laparoscope. That's a recent development. That is basically a microscope telescope that is inserted through a small incision. A second scope is inserted. That scope has an operating head on it. The surgeon can work through the two or sometimes more scopes in body cavities. They can work in the chest, they can work in the abdomen, they can work in joints through the laparoscope. But anyway, bariatric surgery, when successful, is extremely cost effective. Obesity is an extremely costly disease. Surgery in bariatrics is not uniformly successful. You've all read stories about patients who've had various surgical procedures and gained the weight back. But the one question that I would pose is, does bariatric surgery legitimize obesity? The American Medical Association now classes obesity as a disease, and it is a very costly disease. Changes reported in the literature that cause obesity are diet changes in America, lack of exercise. There is a genetic component, no doubt, and obesity is often associated with mental illness, particularly depression. Moving on to the letter C, cancer. When I entered the practice of medicine in the 1960s, a fair number of cancers were discovered at autopsy. They were previously unsuspected. Now, early diagnosis is common, in part due to screening, and there is controversy about screening. We'll go over some of it, but mammography screening is the subject of significant controversy, when to start, how often to do it. PSA testing for males as a cancer screening procedure that is highly controversial. When, if ever, to do it is being debated. Colonoscopy as a screening procedure, extremely controversial about colonoscopy. But the positive for cancer. Now cancer is treated by 3 distinct modalities. There is a surgical approach to cancer, there is a radiation approach to cancer, and there are chemotherapeutic agents, oncology drugs that are used to treat cancer. Most cancer today is treated after a tumor board meeting. Tumor boards are a round table of all the treating partners, surgery, radiation, and medicine, who interchange their thoughts, their recommendations, which is to go first, how much, does that delay the surgery, or should the surgery go first? These discussions are open to all hospital staff. Unfortunately, they're not open to patients yet. I'm an advocate for opening them to patients. I attended as many tumor boards as I possibly could on my own patients. Number 1, for my own education, and number 2, hopefully to be able to communicate what specialists might be a little less able to communicate. Recent scandal in chemotherapy, you may have read it, it's featured on 60 Minutes. The drugs in chemotherapy are sinfully expensive, and it was determined recently that several oncologists are sharing in the rather obscene profits of those drugs. D, dermatology and plastic surgery. Major changes. First one I want to talk about is burn care. When I entered the practice of medicine, the burn care was basically that done in World War II. Since then, major advances in burn care. Better anesthesia for burn patients, better debridement of burns, better skin grafting techniques, better medicines, better understanding of the food and electrolyte shifts that occur in burn patients, and better able to manage that. In the dermatology field, I'm going to include reconstructive surgery, particularly cleft palate. I mean, that is just an amazing advance in medicine. Kids born with cleft palate, if they can afford it, can get it basically cosmetically and functionally fixed. There's a dentist here in town who volunteers his time in that. There are other prostheses that have come along. Elective cosmetic surgery is huge. Liposuction, augmentation procedures. There's been a proven reduction in skin cancer. Those who are at risk with skin cancer should be screened by either a competent family doc or a dermatologist on a yearly basis. That information basically came from the Australians. They have a huge problem with malignant melanoma there because of their sun worshiping culture. The bad news, as I see it, tanning booths are still open. They cause skin cancers, and sunburn is not an uncommon occurrence today. Many of the advances in this field facilitated by the military. Endocrine is the letter E. Endocrine glands are those glands in your body that secrete hormones. All have been extensively studied since I entered medicine. One of the first sentences in a textbook that I used is, "Forget all else, the pituitary gland is king." That statement was true then, it is still true. The pituitary makes many hormones that control other glands. But I'm going to switch and go to the thyroid gland. The reason I chose to focus on the thyroid gland tonight is that there are many advances in thyroid medicine since 1965. Thyroid disease is a broad spectrum of diseases, all of which are fairly common. Let's first talk about benign diseases of the thyroid gland. If your thyroid gland makes too much hormone, it is called thyrotoxicosis or Graves' disease. If it makes too little, it's called hypothyroidism, or often associated with a goiter, an enlargement of the thyroid. In the very aged, my age, hypothyroidism is a difficult diagnosis to make because many of the changes look like aging. So it's a difficult diagnosis. Physicians need to be alert. In the very young, if you miss hypothyroidism, permanent mental and growth retardation occurs. So in the two age extremes, very important. Then you switch the coin to the malignant disease, and there's something interesting about malignant thyroid disease. It almost appears as though there are two diseases. If a malignancy in the thyroid is detected in someone under 30, the disease generally has a pretty benign course. If it's detected in somebody over 30, it is much more difficult to manage. That's sort of the flip of most cancers. Diagnosis of thyroid disorders, both benign and malignant, is now today almost uniformly done in part with needle biopsy. Needle biopsy is a major advance. Needle biopsy involves a long needle that, instead of having a bevel to enter a vein or an artery or an organ in a smooth fashion, has little tiny teeth on the end of the needle. By turning the needle in the organ, tissue is pushed into the bore of the needle. The needle is then withdrawn and the tissue specimen, tiny, is pushed out the other end and go to a pathologist. Pathologists are extremely skilled today at evaluating needle biopsies. I spent Wednesday morning sharing with the pathologist a review of some slides on a patient of mine. For me, medicine has always been fascinating. Almost all good pathologists have 4 eyepieces on their microscope, 2 for them and 2 for anybody that wants to sit and review slides with them. And I have always found that absolutely fascinating. So the diagnosis of thyroid is often done by needle biopsy. The other diagnostic test for thyroid applies to other organs, as does needle biopsy, and that is using a radioactive substance. The thyroid gland loves iodine. Without iodine, it doesn't work very well. And if you give a patient radioactive iodine, it is concentrated in their thyroid. If you then put a piece of film that's sensitive to radiation in front of them, you get a scan of the thyroid. They are very sophisticated, can be very, very detailed. Treatment of thyroid disorder. If you have too much thyroid, the gland is making too much of the hormone, surgical treatment is available. You can remove all or part of the gland. Drugs are available which lower the activity of the thyroid gland, and you can just give them more radiation and sort of kill their thyroid with radiation. If there's too little thyroid being made, you can replace it with synthetic or animal source thyroid material. Wednesday morning, there was a display at the hospital on some new drugs. There is a new thyroid medicine just hit the market. It's a liquid in a gel capsule. It has some advances over the other previous thyroid treatments. Under F, fractures. I'm going to discuss only one class of fracture, and that's fracture due to osteoporosis. Since 1965, there's been an increased incidence of the diagnosis of osteoporosis and an increased incidence of fracture. And that's kind of an enigma because we now have treatment for osteoporosis. So why is the incidence of a disease that we now have a treatment for still going up? Well, it's due to a number of reasons. First of all, the diagnosis of osteoporosis is not sexist. Men get osteoporosis, and we have learned to look for it in men. The population of the United States is aging. That's another risk factor for osteoporosis. Furthermore, since we have a treatment, maybe doctors are just a little bit more aggressive at looking for osteoporosis. Now we understand the risk factors for osteoporosis, particularly in women, but it's true in men as well. The risk factors are Caucasian, small skeletal frame, family history, advancing age, and lack of weight-bearing exercise. There's one other thing that's very important in women with osteoporosis, a concept that has been elucidated for a while. It's not clearly understood by a lot of lay people yet, and I think some doctors still are a little slow on the uptake. The concept of the bone bank in women. Women can build stronger bones till somewhere between 18 and 25. Then the doors to the bank close and they can no longer, on their own, build stronger bone. So if a woman starts to lose bone mass and bone strength, it needs to be treated. We have good treatment. Fosamax is probably the one that most of you know. There are other treatments. H, hepatitis. There are many types. There's been an explosion of knowledge about hepatitis since 1965. Our current textbook, maybe I didn't bring it, I thought I did. Anyway, a current good medical textbook has 58 entries under the topic of hepatitis. A lot of entries on the index. Hepatitis is inflammation of the liver. The most common cause is alcohol, but it can follow many infections. In a previous lecture, we talked briefly about yellow fever. Almost always viral. The spurt of interest in hepatitis was occasioned by the fact that we learned that if you transfuse blood from a patient who has hepatitis into a patient who doesn't, he may well come down with hepatitis. So it was the Red Cross that really spurred a lot of interest in getting their blood bank safe, huge interest in hepatitis. We don't have good techniques to look directly at viruses, which cause most hepatitis. But viruses leave chemical footprints all over the place, and we have gotten very good at defining the chemical footprints that viruses leave. So we can generally find viruses, we can detect them in blood, plasma, we can detect them in saliva, we can detect them in stool, we can detect them almost anywhere. So right now, transfusion medicine is thought to be very safe. There is a major controversy about hepatitis C. This is a type of hepatitis that is sexually transmitted and transmitted with needle sticks, contaminated needle sticks. It's common in the drug culture, still is. The issue is, who should we screen for hepatitis C? Now, there are some very smart people in medicine who say we should screen everybody who was born between 1945 and 65. Those smart folks say that there are several reasons we should screen. First of all, it's a communicable disease. It can be passed, again, sharing needles, smoking from the same pipe, and sexual contact. And a person who has hepatitis C should know that. Patients who have it should also know that even one alcoholic drink bends the curve downward in the progression of hepatitis C. They should not drink any alcohol, and there are many drugs that are metabolized, handled through the liver. They shouldn't be taking those drugs. Third reason they should know: cancer occurs in, depending on the author you read, somewhere between 10 and 15% of patients with hepatitis C will progress to cancer. Fourth reason they should know is we have curative therapy. The problem is that the curative therapy is approximately $150,000 per case. So there are other people who say we really don't have anything to offer with that price, so we should not screen. I have a definite position on that. I think it will come out as we go through this lecture. I think it does beg the question, though, when there are experts on both sides of an issue, do we have a unified healthcare system in the United States? I, the Bureau of Indian Affairs. The health provisions of the Bureau of Indian Affairs were transferred to the Department of Health, Education, and Welfare in 1954 as the Indian Health Service. They have a budget, an annual budget of $4 billion. But that money covers 2.5 million Native Americans and Native Alaskans. That figures out to $1,600 per patient. That is far less than is spent on each patient in the United States per year. J, joint replacement, was not done in the 60s. It actually began in the late 70s. Now it is common. It is uniformly good. There are several patients in this room who have had joint replacement. The good results are due to improved surgical technique, shorter anesthesia, earlier mobilization, better devices. Controversy, some, Stryker Corporation just settled for a hip replacement device that wore out much earlier than anticipated. But in general, the appliances are better. Hips, knees, shoulders, and elbows are done fairly commonly. Wrists and ankles are still in the very early stages of development. The letter K for knowledge. How does your doctor keep up? The new ways, electronic devices. The residents that I taught this morning carry these devices. In those devices, they have full textbooks. They have programs with pictures of every tablet and capsule sold in the United States. They can identify those. They have pictures of dermatologic diseases. They have formulas to calculate the fluid requirement of a burn victim. They have formulas to calculate the dose of a 6-pound baby. Just amazing amount of information in the electronic devices. But the established ways are still how your doctor keeps up. There are excellent textbooks, many of them online. People are still writing very good textbooks. There are journals. I get a lot of them electronically. I still get some of them by mail. There are some examples on that table if you want to just see some. We talk about peer-reviewed journals. I think that's an important concept. What I try to read are peer-reviewed journals. If I write an article, I send it to the editor of a journal. He sends it to several of my peers. They read it and they report to the editor whether my article is sound or not. If it is sound, he may publish it. If my peers say it means nothing, it's in error, that article gets scrapped. So peer review is an important part. And doctors still go to conferences, many of them. You can go to conferences that deal with a single subject. You can go to a 5-day family practice review course where all that aspects of family medicine are discussed. Ways that doctors keep up that are fading, grand rounds. The classic chairman of the department followed by the senior fellow, followed by the resident, followed by the intern, and you walk through patient rooms on rounds. I did that a lot. But now almost no primary care physicians are doing hospital rounds at all, so they aren't in there. Grand rounds are shrinking. It's basically house staff only at the present time. Another way that I learned and kept up was autopsy. I was in the autopsy room probably about twice a week during my training. Autopsies are not done routinely anymore. Essentially, the only autopsies done in Macomb County now are forensic. You know what I mean? Sudden, unexpected, or violent death. The coroner does the autopsy. And they are almost never attended. Another way your doctor keeps up is kind of interesting. The term that you need to hear is metrics. There are people measuring doctors' performance. HEDIS, Health Effectiveness Data and Information Set. This is a nonprofit group that gathers data on physicians. Do physicians get their patients' pap smears current? Do they get their mammograms current? Do they immunize their kids? Do they immunize their adults against flu and tetanus and that kind of stuff? And these records are available often to the doctor, often to the insurance company that pays the doctor, and there is beginning to be a swing where doctors are penalized for low HEDIS scores and rewarded for exceptional HEDIS scores. That's part of the work I do in this other job I have. In addition to HEDIS, there's NCQA. This is the National Committee for Quality Assurance. They do basically the same thing. Their focus is principally on managed care patients, but their data is available. And again, same thing. If you have a managed care patient population, you will be inspected by NCQA, and you may get a bonus, or you may get your income slashed. L is for laboratory. I'm going to discuss several aspects of laboratory. Basic chemistry, your blood draw, usually goes to a big machine called an autoanalyzer. My wife put in one of the first ones west of the Mississippi River when we were in Des Moines. But these machines can do a multitude of tests: your blood sugar, your liver enzymes, your blood count. These are basically done through automated machines. Interesting, the cost of doing the test has gone down. The charges have not gone down. Histology, or the study of tissue through a microscope. There are much better slides, much better stains. Frozen sections are now common, particularly in breast biopsies. I frequently go to my pathologist and sit and look at these slides. Most of them are from needle biopsy today. In the field of laboratory bacteriology, there are new, much better culture media. What we put your sputum on that grows bacteria, we have developed much better ones that are much more specific. So determination of what bacteria has infected you is more precise now than it was before. The rate limiting step with that is that it does take time for bacteria to grow, even with the best of media. So usually in a seriously infected person, we start with a broad spectrum antibiotic. As the culture results become more available and we can figure out which bug it is, we can usually narrow the spectrum of the antibiotic. The narrower the spectrum, the better the antibiotic is for you. In the field of virology, this is essentially new in the last 5 years, and again, other than research labs, we don't look directly at the viruses, but we look at their chemical footprints. We are quite good at that. Forensic laboratory medicine is a field unto itself. You all get exposed to it every time you watch the murder mysteries on television. But it is a rapidly advancing field. Measurement of blood alcohol, measurement of drugs, even drugs that were consumed by a dead person hours and days and weeks ago can now be measured. DNA is huge in the forensic area. It's huge in criminal cases, particularly sex crimes, but it is also very useful in mass casualty situations. You can identify corpses by their DNA. Moving on to M, mammography. It is proven. It is amazing. It has an error rate. It is not 100%. It is still costly. There's still some radiation exposure to the woman who gets a mammogram, and there's still some controversy regarding frequency, when she should start, how often she should have it. There is a group I want to acquaint you with called the United States Preventative Health Task Force. These are some of the brightest people in medicine who serve voluntarily on this task force. The task force meets as often as every other week, sometimes less. It is a private group. It is supported by your tax dollars to this extent. The federal government gives them the space. The federal government gives them technical secretarial support to record their minutes. The federal government pays for their printing. Other than that, the federal government has no involvement. This is a group of very smart people who try to think of what is best for the United States citizen in terms of preventive health. They don't deal with management of disease, but when should you have a tetanus shot? When should you have a flu shot? When should you have a shingles shot? How many mammograms should a woman have? Those are the kinds of things they debate and write reports about. I read those reports very carefully. These are some really good thinkers in medicine. They deserve our attention and our thanks. It's voluntary. Most of the people are from the major institutions. I do have a personal connection with one. She's an RN from the University of Michigan. She is a PhD RN. When she was invited, the University of Michigan was very glad to have representation on that task force. So she got some perks with her job, some additional time off and perhaps a less teaching load and that kind of stuff, but she does not get paid. Nephrology, the initials CKD, chronic kidney disease. In 1965, when I started, if you got chronic kidney disease, you died. We had almost nothing to offer you. Now, dialysis, either peritoneal or the machine, kidney machine dialysis, or kidney transplant. Also, we have learned early diagnosis of chronic kidney disease. We do much better with that. And early treatment, including we are now aware of drugs that are dangerous for the kidney to metabolize, so we try to avoid those drugs in patients. Actually, hemodialysis, the machine dialysis got a big boost from two crafty surgeons. In the early days of kidney dialysis, we had to enter an artery and a vein each time the patient was hooked to a machine. Entering an artery or vein is dangerous. It tends to damage them. So there was a rate-limiting step with kidney dialysis. Once the patient ran out of suitable arteries and veins, they were done. Two wily, crafty surgeons determined that why don't we make a shunt? Why don't we connect an artery to a vein, and if we use that blood right out of that shunt, we wouldn't need access to a separate artery and a separate vein. So almost all patients undergoing hemodialysis, dialysis with the machine, will have a shunt in their non-dominant arm. It's often done when you anticipate the patient is going to need the dialysis machine. Those guys don't get a lot of credit, but they were very smart. Oh, Obamacare. This topic will be taken out of order. We will conclude our discussion tonight with Obamacare. So we go to pain management as P. We as physicians have done a terrible job of pain management. We overutilized the new synthetic narcotics. The overuse was because we were being told that we were not managing pain very well. There was pretty much a national outcry that patients were being left to suffer a lot of pain, and here we had these new, much safer narcotic drugs that we could use. Well, we overdid it. We not only got patients addicted to these drugs, but apparently young people particularly seem to like the feeling they get from taking these drugs. Right now in downtown Detroit, a single Vicodin tablet has a street value of between $15 and $25. So, huge abuse of these drugs. We are trying to do better. One of your government agencies, State of Michigan Health Department, has a website that I can go on using my ID, and I can find out exactly what narcotics any patient of mine has taken for the last decade. So if the doctors choose to use it, they can be very careful about who they give narcotics to. P is also for pharmacy. One aspect that I want to talk about very briefly is a scary thing that I have read recently. Many drugs used today commonly in medicine are extremely expensive. There are authors, principally FBI authors, who state that as many as 20% of the drugs that are very expensive are counterfeit, sold in the United States. It's a scary statistic, but it's big money, and it's short way to profit. You can make drugs that look exactly like the real thing very, very cheaply. Viagra was one. Turns out that Mexican pharmaceutical people were making Viagra out of drywall paste. Looked exactly and was packaged exactly like the real thing. Q, quadriplegia. I'm going a little bit round the barn for this one. Quadriplegia is the paralysis of all four limbs, paraplegia, 2 limbs, resulting from spinal cord injury or spinal cord surgery in the presence of tumors. For this and for certain other conditions, including macular degeneration and type 1 juvenile diabetes, stem cell transplant is taking place. The first stem cell transplant took place in 1968. It was a young man who was born with a genetic deficiency in his immune system. He had a sister. Stem cells were harvested from her, transplanted to him, and he survived into adulthood. So stem cell transplant is not brand new. But in 1981, a significant development occurred. scientists, basic scientists, isolated stem cells from mice embryos. And they determined that the stem cell from the mice embryo was pluripotent, Pluripotent. The stem cell from a mouse embryo could become any cell in the adult mouse. There is no other stem cell that has that capability. So if you are going to do stem cell research in humans, it is probably pretty clear that you better be using human embryo stem cells. That is why stem cell research is not paramount in this country. It is much more intense in Canada, France, and Germany than it is in this country. The religious right and other, I don't mean that in a disparaging way at all, but the religious right is steering us away from human embryo stem cell research. It's being done in other countries. It is an area of medical research that I enjoy because you have to be a pretty good sleuth to even find articles. I mean, nobody wants to publish that they're doing human stem cell work in the United States. I use the letter R for the rank of the U.S. healthcare system. It's going to be brief. When evaluating the United States versus other countries, there are several critical things that everybody needs to think about. Perhaps first and foremost, what is being evaluated? Secondly, who is evaluating and do they have any agenda? And I think there's a third thing. In evaluating the United States healthcare system, I think there is unanimous support for the view that we have the highest technological achievement of any healthcare system in the world. And I would say one other thing. We have some of the greatest physicians in the world practicing medicine and doing research in the United States. But having said that, the Commonwealth Fund, which ranks healthcare systems and has been doing it since World War II, has the following list. The United Kingdom, Switzerland, Sweden, Australia, Germany and the Netherlands are tied for 5th, New Zealand and Norway are tied for 6th, France, Canada, and then the US. That's the way they rank us. Bloomberg, an American evaluation company, long-standing nonprofit, quote, the U.S. spends the most on healthcare on a relative cost basis with the worst outcome. And also notes, Cubans live longer than Americans, but Americans spend more than 14 times as much for less effective healthcare per patient. In my research for this presentation, what I just gave you is basically, I think, pretty pervasive. There are exceptions for sure, but we do not enjoy the unanimous rank of #1 healthcare system. I think that's a fair statement. S for smoking, and I'm going to include alcohol and marijuana. Just a couple things. Taxes on alcohol to the United States government in the year 2013, $5.6 billion. Taxes on cigarettes, same period, 2013, $17.1 billion. Both are legal in all 50 states. Marijuana became legal in Colorado. The state of Colorado collected $3.5 million from the sale of marijuana in the month of January alone. Begs the question, should we legalize it? Should we tax it? Should we continue the war on drugs? I'll leave that to you. A quick statement about medical marijuana. I acquainted you a moment ago with the concept of peer-reviewed journals. There is not a single peer-reviewed journal that has had a favorable article on medical marijuana. Not one. And I watch it carefully for a couple reasons. I'm a member of the Richmond Planning Commission, and we expect somebody to try sooner or later to get a medical marijuana clinic in our city. So I watch it for that reason. I also watch it because I'm a physician. Medical marijuana, who would study it? Would you be supportive If you are a University of Michigan graduate, if the University of Michigan embarked on a major program of studying marijuana. If you are William Beaumont Hospital donor, would you be real happy if William Beaumont Hospital decided to study marijuana? The people who have the most skin in the game are the growers of marijuana, and as far as I can determine, they're a pretty loose group. I don't see them funding a major scientific study of marijuana, so I think that's going to stay up in limbo for a while. The letter T, TIA, or transient ischemic attack. This is a stroke warning sign. It's a transient episode of usually limb weakness, slurred speech, loss of balance, often difficulty word retrieval. In 1965, we knew these warning signs, but we just couldn't do very much about it. From Medicare to the present, we have better blood pressure control drugs, drugs to keep blood from clotting, drugs to break clots if they do occur, recognition of atrial fibrillation, a cardiac irregularity that is almost lead pipe sure going to give you a stroke sooner or later, and better treatment for atrial fibrillation. And we have surgical approaches to decrease blood flow to your brain. We have surgical approaches to decrease blood flow to your heart. We have surgical approaches to decrease blood flow in your extremities. So, need to be aware of a TIA. If you spot one, if you think you are having one, act. Patient needs to go to hospital right now. TIA is a warning sign, almost inevitably followed by a stroke. Same situation with your heart. In males, the usual term pre-heart attack is angina. Exercise-induced pain, pain relieved by rest. In women, sometimes chest pain, more often shortness of breath. If a woman gets short of breath going upstairs, or when she stops, her breath returns pretty quickly, that is an ominous sign, should be seen by a doctor. Interesting to me, there are no guidelines for screening blood flow to the heart. There are no guidelines for screening, to the brain. No guidelines for screening blood flow to the heart. No guidelines for screening blood flow to the leg. We do study them extensively. Lots of people get their carotid arteries ultrasounded. Lots of people get stress tests or cardiac catheterizations. Lots of people get Doppler studies of their extremities, but there are no guidelines as to when to start that or in whom to start it. I'd like to take a minute and introduce the actors who are going to perform a brief demonstration for you. First to come to the area is Miss Gibson. If you would just step forward a bit. Miss Gibson is an RN, and she is the senior trauma nurse in our hospital ER. Miss Marshall, you could even come up. Miss Marshall was a recently retired elementary school teacher, and she is medically unsophisticated. Dr. M is a third-year resident in emergency medicine. At this time, his chief is upstairs at a very important meeting, and the ER is very busy. Dr. M will also play the part of the hospital pager announcer. So, what brings you to the ER today?
Doctor, I'm just tired all the time. I just can't seem to get anything done.
I see. Is there anything else?
I sometimes cough.
So it's tired and cough.
Yes.
Okay, we'll get a CAT scan, I'll get an EKG, and we'll draw some blood work, and I'll be back with you in a few minutes. Nurse, would you go in and see if you can calm down that patient in room 4? She seems a little bit upset.
Well, I recently lost my position
good. What did you do? What was your position?
Well, I was a medical missionary, and I worked with sick people.
And where were you a missionary at?
Oh, in India.
In India.
Yes.
And you said you worked with sick people. Tell me a little bit about what you did.
Well, you know, help feed them and change their beds and you know, move them sometimes. And, you know, general keep up with the patients. And anyway, I just got so tired, and then they asked me to leave. So I was there for about almost 2 years.
Oh, that's a long time. What kind of unit was this? Was it
What was
a
it?
mix of things or?
No, it was the TB unit.
Oh, I see. All right, I'm going to go share this with Doctor.
Thank you.
Well, what'd you find out?
Well, let me go over some of this with you.
Trauma Team Bay 1, Trauma Team Bay 1 staff. Okay, well, I've got 3 kg back and it looks okay, and your blood work doesn't show anything very much. You do have a low-grade temperature. I looked at your CAT scan. I'll have the radiologist review that tomorrow. Meantime, I've been able electronically to send your prescription to the pharmacy, so please stop there and pick up your antibiotic prescription. I also want you to drink lots of fluids and get adequate rest and see your family doctor in about 5 days, okay? Take off. Thank you. There is a prize to be awarded to the audience member who can determine who is the missing person in this skit. The missing person. Medically unsophisticated person entering an emergency room needs an advocate. First letter that we started with, A. She needs an advocate. The prize, who wants to claim it? The prize is the clipboard that we used in our skit. Advocate, but was embarrassed to say. All right, well, prize goes unfunded at the moment. But I hope you recognize the similarities with the first case of Ebola to come into the United States. And that leads me to the letter U, which is my symbol for underutilized procedures. These are done less frequency and with less intensity than I believe they should be. The first is a good and thorough history. The electronic medical record is not user-friendly for physicians to explore a thorough history or to document a thorough history. Usually you have 2 entries, period, no more. So that's the extent that you can go on the electronic medical record. The electronic medical record also takes a lot of time, and presently the electronic medical record does not communicate outside of the one facility where it is used. If Miss Marshall's doctor is not on staff of this hospital, he will have a very hard time getting those records. Second, complete physical exam. Was my physical exam on her complete?
Nope.
Absolutely not. Thorough physical exam is critical. I want to bring that to a rather mundane issue that most of us have dealt with one time or another in our lives. Sprained ankle. There is, I believe on that table, an article called the 12-point ankle exam. To thoroughly examine a sprained ankle takes time. There are 12 maneuvers that you should do to determine the extent of the damage. There are also a set of rules called the Ottawa Ankle Rules. They were developed, believe it or not, by our Canadian friends. And basically they are rules that try to guide a physician towards whether or not an x-ray is indicated. If Ottawa rule criteria are met and you don't need an x-ray, you shouldn't get an x-ray. Now, I'm an osteopathic physician and I feel some trepidation reporting this to you. osteopathic residents, not under my care, but under others, were told and given assignment to learn the Ottawa ankle rules. They were given the task of learning the 12-step ankle exam. The frequency of x-rays used did not go down even when they were supervised. And what this says, according to the authors who did this study, is that physicians have a bias to do more and to test more. I believe that is true. I think this study supports it. So those are underutilized procedures. Another one is autopsy. I learned a great deal at the autopsy table. I think almost everyone who was able to participate in that recognized it as almost a reverential learning experience. I did them frequently during my training. I did them frequently as a medical examiner. Now, I want to discuss something else, and I have another actor in the group. Mr. Vogel, it's time for you to come to your office visit, if you would. I'd like to introduce you to my patient, Mr. Vogel. Jim, I see you were good enough to bring your medicines with you. Okay, if you want to take a seat while I do this, it's fine.
Sure.
What I'm going to demonstrate now is a process called medication reconciliation. It is an involved process. It takes the physician's time. What the physician does is he takes the first bottle of medication that the patient brings in and he asks a series of questions. The questions are, is the medical problem for which this medication was prescribed still an active medical problem? If it is, the second question is this the right medicine for that medical problem today? And that question has to include the cost of the medicine. Third question, are there any side effects common to this drug that the patient might or is experiencing at the present time? If the answer to that is no, you put this drug down and you get the second drug. And you ask the same series of questions. Is the medical problem for which this drug was prescribed still an active medical problem? If the answer is yes, the second question is this the best drug today for that problem, including cost? If the answer to the is yes, are there any side effects to this drug which might be particularly dangerous to this patient? Then there's the next question. Does this drug have any drug interaction with this drug? Then you take the third medication and you do exactly the same thing. Is this medication written for a problem that is still active? If so, is this the best medication for that, including cost? Are there any side effects particular to this drug that might be a problem for him? Does this drug have a drug interaction with this drug or this drug? Same thing with the fourth medication. Now, Jim, can you use all your medicines?
Yeah.
I see a bulge in your shirt pocket. Would you mind?
Here?
Yeah, what's in that pocket?
Just nose drops.
Nose drops. Do nose drops have potential side effects? Can they interact with other medications? Do patients usually consider nose drops medicine? I see something else in that pocket. There's a little...
It's just
What are those?
a sample drug thing I got.
Sample drugs. Do patients consider that the drugs they get from their physicians that are, quote, just samples, a serious problem? Every one of these drugs needs to go through the process of medication reconciliation. And the question that I pose to the residents I teach and to my colleagues is who should do that? Well, in my judgment, it's the family doc that should do it. Pharmacists can do it. Pharmacists have the software programs that do this. But the issue is if you are getting drugs from 2 or 3 pharmacies, they may not know, probably don't know. And if you are getting samples or using over-the-counter drugs, the pharmacy doesn't know it unless you tell them. So In my judgment, this is a primary care physician responsibility. It should be done every time the patient comes in if there has been any change in their medication whatsoever. I did medication reconciliation for a distant relative. She had had major back surgery. She was on 14 medications, 7 of which had as a side effect drowsiness. She fell asleep driving her near-new Subaru, crossed the center line, and rubbed about $7,000 worth of damage off the left side of her car because she fell asleep, taking 7 medications, all with a side effect of drowsiness. When I sent her the paperwork on what I had done in the medication reconciliation project, she took it to her doctors, none of whom knew what the other was prescribing. She was getting pain pills from her operating physician. She was getting pain pills from a pain management specialist. She was getting pain pills from her family doctor. So, medication reconciliation. If I leave you with anything tonight, it's TIA, stroke warning, angina and shortness of breath in women for heart attack, and medication reconciliation. Make sure somebody is doing that for you. Thank you, Jim. That was U, underutilized procedures. Moving on to V, the Veterans Affairs. They have certainly been in the news recently. I have a perhaps slightly different view from most people on the Veterans Affairs. They are leaders in several areas. They have the only workable electronic medical record in use today. You should be proud of that because you, the taxpayers, bought it, and you, the taxpayers, are paying some of the brightest people in the world to keep that system up to date. Why is it not being used throughout the United States? Because it does not contain a billing component. Most electronic medical records are really designed by the bean counters in hospitals principally to serve the function of billing. The VA physicians are all salaried, they don't need a billing program. So their electronic medical record is designed to take care of patients, and it does a great job of doing that, but we can't get it adopted. The Veterans Administration has pioneered the team approach to medicine. The VA uses, and I have several in the audience, advanced nurse practitioners, nurses, physician's assistants. They use dietitians, they use counselors, they use psychologists, they use physical therapists, they use occupational therapists, they use speech therapists, and they coordinate the care. They are a leader in that aspect of healthcare. They do research. There's a CD that I have not yet opened. I've opened several of the previous ones. The VA does some absolutely top quality research, often associated with major universities, but they do a lot of them. Certainly their bureaucracy has caused a lot of grief to the VA, a lot of grief to the veterans who depend on them. I would indict the bureaucracy, but I discovered one other interesting fact. There is a United States House of Representatives committee that oversees the Veterans Administration. At least one member has missed over 75% of the meetings of that committee. So where does the problem lie? Does it lie with the VA, or does it lie with the body that oversees the VA, the United States House of Representatives? V is also for vaccines. In 1965, when I entered practice, we had several. In 2014, we have scores of vaccines. There are reasons why we are struggling to vaccinate Americans. Part of it is religious. Part of it is just bum science. There was a British, quote, scientist who concluded that the chemicals in vaccines cause autism in kids, and that set us back a tremendous amount in pediatric immunization. HPV, the human papillomavirus, it is responsible for almost all cases of cervical cancer. It can be prevented if you vaccinate before the first sexual exposure. This is a huge controversial issue. Do you vaccinate 11 and 12-year-olds? Interesting, the governor of the state of Texas, by executive order, mandated it. He caught a lot of flack for that. But it's a very difficult sell. I had difficulty selling it when I was in practice. We don't see enough peds for me to comment on today. Also, in this room, tremendous apathy towards certain vaccinations. Many of my colleagues, many of my friends have not had their shingles vaccination. It's just felony stupid. A close family friend of ours now has ophthalmologic shingles. You can lose an eye, you can lose your life over shingles. I've very nearly lost a patient, probably the sickest patient I ever took care of in the ICU who got there because of shingles. Also, how many in the room are current on their tetanus shots? That's better than average. Yeah. Diphtheria and pertussis are still around. Need to think about it. W, the World Health Organization. It is the public health arm of the United Nations. It monitors disease outbreaks internationally. It assesses the performance of health systems around the globe. It assists with travel guidelines, and it basically gives evidence-based guidelines on many topics related to international concerns. X and Y are chromosomes. The X-linked chromosome is, each person has 2 copies in females, only 1 in the male. The male gives the gene to his daughter, never to his son. The female gives the gene, the chromosome, to both her daughter and her son. Diseases that you know that are related to the X-linked chromosome are red-green color blindness and hemophilia. The Y chromosome indicates the presence of a male. It's passed from father to son only. The Y chromosome is basically useful in genealogical research. It's the one that allows trace the male line through DNA. In 1965, when I entered practice, we had some basic knowledge of genetics. I was a biology major with a major interest in genetics. I had an inspirational professor in genetics. I originally thought I would do genetics as a life work. But what we knew then was trivial compared to the explosion that we know now about genetics. In 2014, the knowledge and the technology has just exploded. There are laboratories now that can select a healthy embryo from an embryo that is carrying genes that would produce disease. There are probably the capabilities for that same lab to select hair color, eye color, stature, perhaps even intelligence. So this is one of the areas where, in my judgment, technology has probably outstripped ethics. I would offer to you that end-of-life care may be in the same situation. We're closing in. Z, zoonosis, Z-O-O-N-O-S-I-S. Who knows what it means? Zoonosis is animal reservoir of disease that can be transferred to man. In 1965, when I started, we dealt with several. One hot one in this community, Richmond, Michigan, was brucellosis. Brucellosis is an infection in dairy cattle, and those of you my age remember that Richmond, Michigan was a center of dairy production for Macomb County. But the term actually is the process by which an animal reservoir disease is transmitted to humans. We had brucellosis, we had Rocky Mountain spotted fever, we had cat scratch disease, we had leprosy, we had tetanus. I was unfortunately able to witness the death from tetanus. Keep your tetanus shots up to date. And tuberculosis. Tuberculosis can be transmitted from man to man, as Ms. Marshall demonstrated earlier. But tuberculosis in cattle, bovine TB, and tuberculosis in the deer herd in Michigan are major issues today. Now we have HIV and Ebola. Those two diseases are a bit different from others in that they are viruses that originated in animals, are now transmitted to man, but they mutate so rapidly. We get a handle on a vaccine and the virus mutates. So that's the problem with those two. Under Z, I want to mention one other thing. Some of you may know this term, the Z-Pack. The Z-Pack is a prepackaged dose of erythromycin. Many patients in my practice lifetime asked for the Z-Pak because they thought it cured whatever they had. Z-Pak is often erroneously prescribed for common colds. Recently, the Z-Pak was found to cause fatal cardiac irregularities in a surprisingly high number of patients. All right, on to Obamacare. The Patient Protection and Affordable Care Act. Let me review just a bit of historic background in the development of the United States healthcare system. As I discussed in a previous presentation, we in the United States did not follow the European model. We sort of went out on our own and designed our own system. We do not have national health care, and we do not even have a national system for health care. Think about the Ebola crisis. Every president of the United States since Harry Truman has recognized the need for some degree of change in our healthcare system. The rising costs of United States healthcare, especially within the past 10 to 12 years, based in large part on the excellent technological advancement, are widely viewed as unsustainable for this country's economy. 30 years ago, at a national conference of hospital physicians, chiefs of staff, and hospital chief administrators, which I attended, as did my wife, the keynote speaker raised this question: is basic health care a right or a privilege for the citizens of this country? He then went on to state that our technology for medical advances would soon outstrip the country's ability to pay for these advances. He predicted that this subject was so charged that no politician would touch it, and he was correct until the election of our current president. Here is a copy of the Affordable Care Act. I have read it. I know of no one else who has. The two main goals of the Affordable Care Act are to provide some degree of insurance to all. Quote, before this act, every family in the United States, except the wealthy, was one medical catastrophe away from bankruptcy. Providing some coverage to significantly more citizens would result in bending the curve of the rising rate of healthcare costs. How would it do that? 4 ways. Being less utilizing of the emergency room. The emergency room is extremely expensive. It should be used for patients with serious health problems, but health problems that can be taken care of in a less expensive setting should be. By greater access to screening, thus arresting disease progress early, cheaper treatments exist. By emphasizing the management of chronic disease states with a health care team, nurses have a major role under the Affordable Health Care Act. So do social workers and physical therapists and occupational therapists. With better management and some financial resourcement, patients might be more willing to go to their doctor for follow-up when these kinds of problems arise. And the 4th way is an interesting one, by shifting more payment to performance and outcome rather than on procedures. The Affordable Care Act was not written by President Obama. It was written by our legislative aides, those who serve our elected representatives. Lobbyists from physicians groups, hospitals, pharmaceutical companies, insurance companies, durable medical equipment manufacturers, AARP, home health care agency, and nursing groups gave much input and spent much money on lobbyists to maintain their individual goals in the preparation of the act. It is obviously not a perfect act. However, it does speak to the 2 major goals. There are no death panels in the Affordable Care Act. That was widely reported. It is an absolute falsehood. Insurance companies today play a major role under the Affordable Care Act. They are competing for your and my membership, particularly they're active in the area of benefits and premiums. I would say to you that somewhere between a third and a fourth of the ads that I see on television right now are insurance companies soliciting your participation in their individual plan. This is not a single-payer system. The Act does mandate some requirements for insurance companies. You're probably familiar with most of them. Pre-existing conditions. Children are allowed to stay on with parents till age 25. One that's important to me, ALS, Lou Gehrig's disease. The insurance companies, with some justification, said this: we will pay for physical therapy as long as the patient is improving. If the patient fails to continue to improve, we terminate the physical therapy. A disease like Lou Gehrig's is not going to improve. But with continued physical therapy, the patient may stay ambulatory for a significantly longer period of time, may be able to toilet himself or herself for a longer period of time, may be able to eat for a longer period of time, may be able to be taken care of at home for a longer period of time. But they are not improving. They are still continuing the inevitable downhill course. The Affordable Care Act says to insurance companies, thou shalt not terminate physical therapy. To me, that's a very humanitarian and morally correct position. Finally, there is something else about the Affordable Care Act that I think is laudable. The Affordable Care Act contains in the Act provisions to evaluate key areas of the Affordable Care Act with a time frame, and it demands revision if that portion of the Act is not achieving the target goals. I know of no other legislation that I have ever studied for anything that contains, in this month, the Secretary of Health and Human Services shall reevaluate this program, and if it is not at target, restructure the program. So, there are phase-ins on the Affordable Care Act. It's not all in place at the present time, more will come. I'll leave this right here. There's sort of a summary of the Act here, if anybody wants to see it. There are various articles on the two tables over there. You're welcome to see them. I'd like to have them all back. They deal with certain aspects of what I presented tonight. I'm deeply grateful for all of you coming. I'm deeply grateful for the attention that you showed me, the courtesy and respect, and I thank you. I'll answer any questions.
You said that on that ankle thing, we did more testing in the U.S., the doctors did. Would that be because of the lawsuit?
Yes, ma'am. Yes, ma'am. I did not touch on medical malpractice. It's an ongoing problem. It's partly because of the lawsuit issue, but it's also because doctors have a bias. Do more, as opposed to play by the evidence. I mean, in the issue of the antibiotic overuse, doctors well know this is a virus. It's going to get better all by itself. Don't write antibiotics, and yet we continue to do it. There's a great article on sinusitis. There are authors, I think reputable, peer-reviewed, that say antibiotics have no effect on mild sinusitis. Then they say antibiotics have no effect on medium sinusitis. They go on to say antibiotics have no effect whatsoever on serious sinusitis. Sinusitis is basically an abscess. The treatment of an abscess is incision and drainage, period. Every nurse in here will tell you that. You cannot incise and drain the sinuses. It's done sometimes, but basically what you can do is change the fluid in the sinuses. Get more hydration, inhale steam, stand in a warm shower. That's what breaks loose sinus congestion, and antibiotics, basically they can't get there. It's a cavity. They don't go into a cavity. So are we still right? And we still x-ray ankles when they shouldn't be. Other questions? I'll try.
When you mentioned physicians not making rounds, is that a result of the liabilities? Or what is the reason that you see
can make
fewer family physicians in the hospitals
There are
attending
none.
their patients?
There are none now. None.
Yeah,
You can make more money staying in your office, is the simple, short answer. I'm not going to brag. I was trained to make rounds. I continue to do it, as you know. I just so much enjoy interactions with specialists. I told every specialist that I associated with, if you see me practicing substandard medicine and you don't tell me, I'll find another specialist who will. So I had an ongoing interactive relationship with the specialists.
but the explanation to the public seems to be they can't afford it because of the extra liability that it costs them. This is what I've heard. I don't think that's the only thing.
No, it's
No,
you can make more money staying. You can make more money staying in your
That's
office.
the public perception.
And that may well be, but at McLaren, most physicians now are hospital-owned and salaried. And they have a financial target. And if they don't meet that financial target, one of those bean counters is in their office right away, renegotiating their contract. So they stay in their office. Sure.
Why is it that hospitals advertise?
Show me the money. They want you in there. They want you in there. And
You don't see Blue Cross Blue Shield much on TV though.
well, Blue Cross Blue Shield is in the fight of their life because other insurance companies have successfully penetrated the Michigan market.
I have been with Blue Cross Blue Shield since my husband passed away. And I have no problem. And, well, I got a lot of problems and they pay us.
Yes, you are very fortunate. You would be considered medically elite in terms of finances.
And I
Because you
got
have an
another
excellent.
one, big one coming up
Yeah.
now. So
Yeah,
I hope they pay.
they will. Any other questions or discussion?
Can I show you something I received today?
Sure. If you bring a pie.
Can't have two in one. Free pump.
Oh, yeah, yeah. Yeah, I would tell you about that, I know a lot more about that. Yeah, this is a notice that she got of the outreach of an insurance company that is going to an accountable care organization. Now, if you want, we can discuss ACOs for a minute, accountable care organizations. Part of the job I am doing now deals with accountable care organizations. Basically, I'm going to summarize this as general, don't hold me to specifics. Medicare says to a group of physicians, if you want to form an accountable care organization, we will assign a certain number of Medicare patients to you. And at the end of the year, we will bring a bunch of money in a big bag and we will put it on the table. And that money belongs to you physicians and the hospital that's in your accountable care organizations and the radiology suite and the pathologist and anybody who participates in taking care of these patients. You guys divide up that money. Now, if they bring money, that's a good deal. But if the accountable care organization fails to perform, if the costs in the accountable care organization are too high, then they don't bring any money. And they may ask for money. So it's accountable care. That's what you are in. Does the accountable care organization work? There are about 50 accountable care organizations in the United States right now. There were about 70. 20 dropped last year when the government said, not only are we not giving you any money, you owe us some. Of the 50 that are operational right now, I think it's about 50-50. 25 are making it and look pretty good. 25 are kind of on the bubble. Because what this does is, I'm the family doctor. I find that your hip joint has gotten so bad, you are going to need surgery. I am then in a position to negotiate with the orthopedic surgeon. There's only going to be one bag of money on the table. You used to get $8,000 for doing a hip. I want you to do it for my patient for $7,100. It's my patient. You're just the orthopedic surgeon. Puts the primary care physician in a very strong position in terms of where the money is going in healthcare. That's the basic philosophy behind an ACO. Hopefully, with everybody willing to take a little more, looking for the bonus that Medicare will give if your performance is outstanding, the cost curve gets bent. That's what an ACO is.
But I also heard, this is from a cardiologist, that some organizations or insurance companies, if you are over 80 years old, that if you need, like, say, heart
Transplant.
yeah, they will not pay because you're too old and it's too much of a risk and all this. Now, this is a cardiologist talking. He's Dr. Washington.
He is absolutely right,
Yes.
but it is not the accountable.
Not yet.
It is
No.
not this act that does that.
Oh.
It is insurance companies that set
Yes.
those kinds of benefit limits.
And he's doing surgery on me, so
He's lucky.
I hope.
To get a chance to be with you is
I believe so.
I have a question that's kind of involved. What do you think in regard to the benefits or drawbacks of Obamacare in regard to, say, the poor people, the middle class, and the upper class? Also in regard to age, the kids, young babies, kids, middle age, and older. This involves a lot of different questions.
The Affordable Care Act is studied in many, many different ways. I will give you my personal experience. Our medical outreach clinic goes to the poorest areas in this county. To get aboard, you have to be in poverty and have no insurance. You have to prove that before you can get on. Our census is dropping rapidly. The project that I had a hand in starting 20 years ago may well die because more people have insurance. There's huge discussion. As a matter of fact, Mrs. Marshall subscribed to a publication for me. There's an article back there on the effect of Obamacare on the economics of the nation. And it is not all favorable by any stretch of the imagination. The economics of the Affordable Care Act are extremely complex. My wife handles our finance. You are looking at one of the least talented people in terms of understanding economics that you have ever been in the room. Trust me, I do not understand a lot of the finances of the Affordable Care Act. I do understand the principle. If we can get more people insured, more people with skin in the game, we can probably bend the cost curve. That is happening. Did you print off that article today?
No, I didn't.
That's okay. There's a current article, New York Times,
Yeah.
showing that the cost curve is bending downward. But what about the cost to a small shop owner who has to insure his employees? Different story, and I don't know the answers to those.
Yeah.
It's just, the answer to your question is, I don't think anybody is
Very involved.
Yeah, I don't think anybody knows. I don't think there's a single reason.
The very first thing you said was the advocate. Is that automatic when you go to a hospital?
Not unless you do it.
primary care, or all of you?
Certainly, if you have a relationship with a primary care physician who treats you with dignity and with courtesy and respect and spends the time to explain stuff to you, I don't think you need an advocate when you go to see your primary care physician. But basically, with most specialists, some exceptions, I know some specialists who bend over backwards to teach patients and to make you fully informed and make you part of the decision process. There you don't need an advocate. So when you walk into an unfamiliar situation, a hospital, ER, I think you need an advocate. You need somebody that, it doesn't need to be a physician, it probably doesn't need to be a nurse. But I think almost everybody recognized that I was crude, rude, and ineffective with my TB patient.
So if an advocate had been there, do you think you'd have treated them differently?
What would you have done if you were the advocate?
Well, I would have been objecting, but I'm not, with the way you presented yourself, I'm not sure you would have listened anyway.
If you speak, I will listen.
You know my point.
But truly, an advocate has to be willing to be the patient's advocate. Doctor, she doesn't seem to understand, I don't understand. Why are we doing this?
I know a young person who right now has 4 or 5 pulmonary specialist, oncologist, a surgeon, a primary doctor, and then an advocate. And all of those people meet together.
Yeah, that's, again, if I go into a hospital ER as a patient, I want my wife there. I definitely do. I want an advocate.
Well, most physicians will say your wife knows more about you than you do.
No question about that. And we'll broadcast it.
Another reason for a second person is we don't always hear everything.
Absolutely.
Or understand, and the other person will
Absolutely.
interpret
Just for somebody who is facing orthopedic surgery and may face physical therapy afterwards, one thing I have tried to teach my patients, get somebody to take a video camera to your physical therapy last session. Video yourself doing the exercise program exactly as the therapist wants you to do it. Put it on a CD and you can play it every time you are supposed to do your exercises. Right, Tom? Yes. Yeah, communication is really where this is. That's what the advocate should be doing. What was that? I missed it.
You don't need a camera, no, you just use your telephone.
You have to run a camera.
Thank you, Dr. McClellan, for this wonderful presentation. Only twist on the ABC song.
And thank you, I think, are you Betty Crocker tonight?
Oh. I guess I was, yes. But we're not going to think about that when we think about the ABCs that we just went through. So, thank you.
You're more than
Dr.
welcome. I
McClellan.
enjoyed doing it.
And a little something from the society.
Thank you.